Good afternoon, and thank you, Professors Khalil, Omar, and Rami. My special thanks also go to Professor Ahmed Okasha, whose relationship has inspired me and led me to being here today. It's an honor to be invited to present this lecture that would have been much more enjoyable if I could be there with you in person. In this lecture, I will present an integrated biopsychosocial view of the role of culture in mental life, which may serve as a prelude to the discussions on culture later in the Congress. Although gaining competence in developing and maintaining a therapeutic alliance in psychiatry has been an important topic of conversation in psychiatry and all of medicine, really, for many decades, it's not an easy competency to gain. And we know the work of psychotherapy is difficult and time-consuming, and not easy in the best of circumstances for both the patient and therapist. One reason for this is that for psychotherapy to work optimally, we need to know as much as possible about who is the person we are treating, as it is to know about their diagnosis, to help guide them effectively. And one very important thing to discover about that person, such as with these fish who are lost, is their culture, which will often be different from our own. Another reason this is difficult is that the kind of learning we are trying to foster in our patients involves, at the most biological level, changing the microstructure and function of the brain. In 2000, the American psychiatrist Eric Kandel won the Nobel Prize in Medicine for his decades of work in understanding the neurophysiology of learning and memory. Kandel found that when a new learning task is undertaken and mastered, the process of storage and long-term memory is genetically controlled. And this leads to changes in neural networks, synaptic structures, and functionings. Once the pertinent synaptic and network changes occur, the memory is stored. And except for the impact of degenerative or other changes affecting the brain, such long-term unconscious memory storage is quite robust. Just think about hearing a song from when you were a teenager and immediately remembering the words, or smelling an aroma that takes you back to your early years. We know that many aspects of our perceptions and the resulting influence on us comes first from significant figures in our early lives, and then from the wider sociocultural environment. These perspectives, which are intrinsic parts of our mental world, are stored in long-term memory, and as such influence our view of the reality of the world around us and the people in it. These unconscious influences were, as you know, described by Sigmund Freud in his writing about the development of the ego and superego, but he couldn't know the neuroscience we know about now. We often describe these perceptions as ego-syntonic, meaning that we think what we perceive is the actual reality. It does not seem to us to be subjective or filtered by entrained perspectives, assumptions, or beliefs. Thus, helping our patients to better understand these phenomena in themselves and to make needed changes requires an extraordinary level of understanding who that person is. When we perceive a patient as similar in some ways to ourselves, it may seem this is an easy process. But such an assumption doesn't often hold true, especially when the person is from a different culture than ourselves. In recent years, the unconscious perceptions and beliefs about someone from a different sociocultural environment than our own has been referred to as implicit bias. The word bias in English has many connotations, and some are negative. But in this use, there's no assumption of negativity or pathology. It simply refers to the manifestation of one's typical development in their own particular sociocultural milieu. Because these sets of perceptions about others seem to us to be reality, it can be difficult, especially when we are with a patient from another sociocultural environment, to try to step back and reflect about our perceptions without feeling defensive. In today's world, with greater migrations than at any time in recorded history, there's less and less likelihood that in our clinical work, we will see only patients with the same sociocultural background as ourselves. Thus, so that we can better understand our patients, we must find a way to better understand our own implicit biases. In the United States, implicit bias training programs have begun to develop as an increasingly important component of our society in the business, government, and medical worlds. The best of these programs last many months, but most commonly, unfortunately, they involve just a day, part of a day, or sometimes only an hour or two. Gaining a new way of perceiving others and ourselves is certainly not a quick process. Freud knew this as well and believed that true self-awareness takes a long period of time to develop, involving many hours of often difficult self-reflection. And it's why he suggested we need to understand our own conflicts, misperceptions, biases, and assumptions before we begin to conduct psychotherapy. Kandel would say the reason implicit bias training, as well as psychotherapy, takes a long time is because insight is gained only when the brain's microstructure and function is changed in a significant way, and for thinking and perceptions to become entrained in a new way. Let me illustrate. I consulted with a very good resident who was seeing a woman in her mid-30s who I was told had a paranoid delusional disorder, but was not responding to antipsychotic medications. This African-American woman was a single mother of 2 children and held a full-time job. 3 months earlier, she had an acute onset of severe anxiety and fear that someone would break into her house and kill her and her 2 children. She had no unprescribed drug use and no other symptoms consistent with psychosis, except she spent several hours each night checking the locks and the doors and windows to make sure that no one could break in. When I first saw her, it was in a very small room, but she didn't seem uncomfortable that I had to sit quite close to her, as I would expect from someone who had a paranoid disorder. Also, when I asked her questions, she seemed relaxed, engaging. She had a good range of affect, though predominantly worried. It seemed to me very unlikely, almost right away, that she had been properly diagnosed, so I tried to go back to the beginning. In exploring the usual possible sources of precipitating events, she answered no to all my questions. There were none. Then it came to me that because I knew from her chart she lived in a neighborhood with a high crime rate, I should ask if anything had happened in her neighborhood. So I did. She said yes. You may have seen in the newspaper there was a shooting, and my next door neighbor's 9-year-old daughter was killed. I did remember that. The wheels started turning in my mind, and I said, "You must have been very scared." She began crying and said it was worse than I thought, because when that little girl was shot, she was playing on my front porch with my 9-year-old daughter. She was really crying at this point, remembering that moment. I asked why she had never mentioned this, and she said her symptoms started 2 weeks later, so she didn't think the killing was related. When she said the medication had not helped at all, I told her I thought she was still extremely frightened, and I thought she should come and talk about that, and that the medication might not be the right treatment. She agreed. The resident stopped her medication, and she began weekly supportive psychotherapy. Her resident later told me she was discharged from the clinic 6 weeks after my meeting with her, with no symptoms. His lack of consideration of a possible environmental event prevented him from discovering the true story. Since he had always lived in a safe neighborhood, he told me, he didn't even consider that possibility, so he never asked. He was a very good resident, but his implicit bias kept him from finding out the real situation. Culture, as we know, plays a significant role in the way we look at ourselves, others, and the world around us. And as we also know, many schools of thought, belief systems, and practices have emerged to foster maintenance of individual self-cohesion and self-esteem, self-awareness, self-regulation, and introspection. One way of describing this kind of adaptive self-awareness can be called insight. I've found a helpful definition of insight, gained through any kind of process, not just psychotherapy, is the understanding of associations between past and present experiences, typical relationship patterns, and the relationship between interpersonal stress, emotional experience, and psychological symptoms. Research, in fact, has shown a moderate but robust correlation between the positive outcome of psychotherapy and a change in the patient's insight. As you know, the major forms of psychotherapy practiced by psychiatrists in most of the world include some version of supportive therapy, psychoanalytic or psychodynamic therapy, and cognitive behavioral therapy. For both the psychoanalytic, psychodynamic, and the cognitive behavior therapies and all their variations, which are often called insight-oriented therapies, the assumption is that some mental processes outside the patient's awareness are influencing thinking, feeling, and/or behaviors which may be maladaptive. Gaining insight is a primary goal of these kinds of therapy. The most well-known formal version of supportive therapy is IPT, interpersonal therapy. It's based on an assumption that a significant event or experience has overwhelmed the patient's usual reasonably adaptive and adequate ways of coping with stress. The goal, as with the patient I just described, is to provide psychological support to help the patient tolerate the stress through the therapeutic alliance. And of course, we all know that therapeutic support's an important part of any kind of psychotherapy. We also know that there are many practical reasons that one or more kinds of therapy might be unavailable. This can be due to the resources available to the patient and very commonly within the local psychiatric community. But there are also many social cultural reasons as well. And we often see patients who lived or whose families came from cultures in which the therapeutic approaches we might normally use may be experienced as incomprehensible or even unacceptable. Here are a few more clinical stories. The young woman was admitted to my hospital service with referral indicating she was having an exacerbation of paranoid schizophrenia due to non-adherence with her medications. When I entered her hospital room, I saw her sitting in a chair with her arms wrapped tightly around herself and an extremely frightened look on her face. I introduced myself, asked if I could sit down. She said, of course. I said she looked very scared to me, and I asked if she could tell me why. She said, some people, I don't know who they are, are trying to kill me. Why are they trying to kill you? I asked. She said, I don't know. I think I've been rooted. I ended the conversation soon after that, and I didn't know what that meant, being rooted. But luckily for me, one of our nurses knew the patient was from the Caribbean. She asked me if I knew whether the patient practiced the voodoo religion, because in that religion, plants or other materials are used to cast spells, either good or bad, and that's part of their religion. Once I learned about this, I went back to see her again, trying to think about how to use my newly understood cultural perspective to foster an alliance and to suggest an effective treatment. I asked her if she could tell me more about having been rooted, and she readily discussed it. And as she was doing that, she visibly became more relaxed. When she finished, I didn't tell her I disagreed with her conclusion that someone put a spell on her. But I did say I thought I might have something which would help her. She was very relieved to hear this. I didn't say the pills I was going to prescribe her were an antipsychotic, which had proved effective according to her old records. If at that moment I would have told her I thought she was not cursed, but only had a disease called schizophrenia, which caused her to be so afraid, she wouldn't have taken the pills. She might even have thought I was part of the group trying to kill her. In this regard, though it may seem unconventional, I will use in my defense the words from a quotation. Trying to tear down someone's beliefs, even with kind intent, is at least as damaging as destroying their personal property. To respect a person is to respect the system of convictions, beliefs, and faith that the person lives in. My patient agreed to take the medication, and it had a positive effect, and she was discharged within a short period of time. When the internist George Engel first published his conceptualization of what was called the Biopsychosocial Model in the early 1970s, he was describing an approach to understanding and treating our patients, which embodied an integrative understanding of the etiology, pathology, treatment, and health. As I mentioned earlier, this means that in order to develop an optimal therapeutic alliance and treatment, we have to understand who is the person with the illness, not just what is the illness. Since people from different cultures now live in communities which are strange to them in many ways, they often feel out of place and distressed, sometimes severely. For example, in my own city of Louisville, a city in the middle of the United States with almost 1 million people, we saw patients from Asia, Africa, Europe, and Latin America in our clinic last year who were not English speakers. They required translation for over 50 languages within our immigrant communities from over 100 countries. Their sense of self, made up in a significant part by their cultural, religious, and spiritual customs, practices, and beliefs, and the myriad subtle and less subtle intricacies of social interactions they had always taken for granted, often needs to be substantially transformed to recreate a new sense of self in a strange land. This critically important task and understanding the social part of the biopsychosocial model is often a key aspect of the treatment process for them. And the social component is often the part that we regard the least. Sometimes, though, even though I try, I don't succeed. Several years ago, I was asked to see a woman from Iraq for the first time. Our female trainee, who was from Southeast Asia, who had been treating her for several months, told me her patient suffered from severe depression and had not improved at all. As I entered the room with our resident, I saw our patient was dressed in traditional clothing, though her face was not covered except by her hands. She was sobbing quietly. Her husband was dressed in typical Western pants and shirt and was sitting close by. She spoke no English, but he did, having worked as a translator. He told me she was depressed and despondent. The day before we were to leave for the US, after we were waiting for a visa for many years, our only son, 9 years old, was killed by a roadside bomb near our house. He explained that his wife was unable and unwilling to talk with us or anyone else about our thoughts and feelings except for him. Antidepressants, not surprisingly to me, had been ineffective in changing her condition. Despite my best efforts speaking through her husband's translation, she wouldn't respond to me at all. Her husband was very apologetic, and hoping to prevent me from feeling offended, he told me that in their culture and her religious beliefs, it was forbidden for her to speak other than superficially with any man who was a stranger, even perhaps to a doctor. Also, he said, talking about feelings at all was not done in our country in recent years because this could be quite difficult. Don't feel bad, he told me. I want you to know, he said, that I'm so desperate to help her that I'm taking her back to Iraq tomorrow morning. He hoped that seeing other family members and old friends might help her. I told him I hoped that would help also, and that we look forward to seeing them when they return to Louisville. They still haven't returned to the clinic. I don't even know if they've returned to our city. And of course, I don't know her condition. In 2016, there was a symposium at a World Psychiatric Association meeting in South Africa, in which the purposefully provocative subject was that perhaps the time had come to discard the view that general cultural background is a specific enough parameter to be useful in understanding a particular individual's mental processes and presentation, or even as an important descriptor to use in describing an individual's mental world. Their argument that culture is essentially that individual's personal culture suggested that it is only at the level of the specific individual with their own specifically individual version of culture that meaningful understanding of who they are and what is their illness would be valid. As I've said, we would all agree that cultural influences are pervasive, but at the same time, we're obligated to address the individual world of our specific patient and not rely on what may be cultural stereotypes, which could be variably present from one individual to another in any case. This symposium reminded me of the first conversation I had almost 3 decades ago with Professor Ahmed Okasha. We talked about many aspects of psychotherapy, including the difficulties in providing psychotherapy services in countries with few mental health resources. The most interesting part of our long conversation to me, though, was the difficulty in some patients' acceptance of psychotherapy due to sociocultural issues. One important aspect of this, Professor Okasha said, is religious beliefs. Western developed psychotherapies, he said, are based on learning new things about one's own mental process. That is, gaining insight, as I've just mentioned, and using that new knowledge to change one's feelings, thinkings, and patterns through self-reflection and guidance from the therapist. This process, he said, assumes that we all have free will. Because of this, the entire idea of psychotherapy, based on a principle that the patient, him or herself, has the power to change themselves, could be considered blasphemous by some people, since that view is not compatible with a belief in many traditional religious teachings that change comes only through prayer and God's intervention. This is certainly an issue we have to address with a significant part of the population in the United States who have very traditional religious beliefs, no matter what their religion. Those individuals are often either unwilling to accept psychotherapy treatment at all, or at sometimes only with a therapist who they feel shares their own religious beliefs. In my own state of Kentucky, the largest such group includes those who share very conservative traditional Christian beliefs. Changing the focus now, though. I recently was asked to consult with one of our residents who had been frustrated trying to treat a woman in her mid-60s from Cuba. The patient spoke only Spanish and had come to our clinic with severe depression. Her recent antidepressant treatment had been generally ineffective, and she was still quite depressed. When I entered the room, her adult daughter and her boyfriend, who served as the translator, were with the patient. When I asked my patient, through the boyfriend's translation, about whether anything specific had precipitated the depression, the patient responded that, yes, several months before, my son had been arrested for murdering someone during an argument. That sounds very distressing, I said. Have you talked with your doctor about how this made you feel? But the translated responses were that she had not and that she would not. At that point, I decided to switch to Spanish, which I don't use very much because we have a very small Spanish-speaking group of patients. I reintroduced myself in Spanish and said, ¿Por qué no? Why not? And I moved my chair closer to her and away from the other two. With a surprised look on her face to hear me ask in Spanish, she told me in a quiet voice that she was not comfortable talking about her feelings, especially with her daughter and the daughter's boyfriend listening from the other side of the room. And she didn't even know the boyfriend. It would not be proper and would shame me, she said. Still speaking Spanish, I said I understood, but I thought it could help her to feel better if she could speak to her doctor. Maybe we could obtain a professional translator. She said, no, I won't consider that. This ended our meeting. The next time I saw her, I greeted her and spoke only Spanish. I saw the smallest smile when I said hello in Spanish. And as we talked, she did tell me something quite important. When she learned her son was arrested, what immediately came to her mind was the vivid memory of watching her husband kill his brother during a terrible argument many years before in Cuba. He was arrested and convicted of murder, and he remains in prison in Cuba. She hasn't seen him for many years. So this current trauma revived memories of her earlier major loss. I told her I thought this helped me to understand how much her son's arrest had affected her. Had you told your doctor this? No, she said. I asked again if she would consider talking in psychotherapy with a translator. Karaoke, no. I think not, was her answer. The next time I saw her, I was met with a slightly larger smile. Our talk evolved around her husband again. And she talked more about how she felt, about what had happened, how she felt not being able to see him, and how lonely she feels. But again, her daughter and the boyfriend were still in the room. I suggested that talking more about these things, as she had been doing to me, but maybe in a more private way, would help. Es posible. It's possible, she said for the very first time. Did I have some special empathic skill that led to this change? I don't think so. I think it was the fact that by speaking with her in Spanish, she felt I was connected with a core part of her, not just her language, but her Cuban self. And I think that made the biggest difference. One final topic illustrates another aspect of culture and approaches to change in psychotherapy. Psychotherapies in many Asian countries have been influenced in various ways by Taoism, Buddhism, Confucianism, Hinduism, or Islam, each with its many strands. For example, Morita therapy in Japan, developed around the same time as psychoanalysis was being established in Europe in the 1920s, is very influenced by Zen Buddhism, but merged with some aspects of Western psychoanalytic therapy. Tao psychotherapy in Korea uses Taoism and American psychoanalytic principles. In the West, the evolution of psychoanalysis and the core philosophy of most therapies practiced in the US and Western Europe, until recent years perhaps, reflected both the religious and cultural context of those societies and the original Greek ideal of the autonomous, self-directed individual and the power of the intellect and will, which is used to maintain self-regulation with domination over nature. The religious and philosophical approaches in Asia, as some of you know well, differ significantly. The psychoanalytic view of the mature self, which influences Western psychotherapies, has certainly changed some since Freud's time, most recently in the object relations and self-psychology schools of thought, which is a topic for another lecture. But Western theories still assume an intrinsic conflict between the self and the outside world, to which the individual must adapt to find harmony in life. Using Korea and Japan as an example, however, the mature mental self in those traditional cultures is not understood as an entity which exists separate from others, or the physical self, or the natural world. It's the harmony of the self in relation to the other and to the natural world that is the important result of ideal individual experience and the maintenance of psychological equilibrium. Morita therapy in Japan embodies the Zen principle that in the mature self, psychological and physical harmony is present, as is harmony with all aspects of the world, both human and natural. Morita therapy, though altered since World War II, like most psychotherapies, still maintains that the goal is for increased self-awareness and harmony with the world, which is unimpaired by the distortions of affects, psychological conflicts, and intellectual processes. The goal is not to completely eliminate or modify dysphoric affects or conflicts, but to accept them as part of existence at the moment. So, if I can summarize, using our empathic listening ability while building the therapeutic alliance and while carrying out psychotherapy is enhanced when we consider the role of all aspects of culture in our patient's mental life, and when we ensure we learn who is the person with the illness. This part of the assessment has been lost since social psychiatry was developed in the 1930s. This takes both time and intention. The process of better recognizing how both our patients and our own mental processes are influenced by our own social cultural influences requires finely tuned, self-reflective, and empathic skills. Such learning can, I believe, be enhanced in many ways, but certainly one important way that is little used now is when our own training includes specific attention to understanding how our own implicit, socioculturally influenced biases about the person or family we are treating may be influencing our perceptions and conclusions about them. Thank you very much for your attention, and I apologize for any imprecision in my own explanations, with thanks to Lao Tzu, founder of Taoism, as you can see from this slide. Thank you again. Hi, this is Allan Tasman in person. If there are any comments or questions, I'd be glad to try to respond. I apologize if the sound was not so good on the tape, at least coming all the way to the US.
Thank you, Professor Tasman, for to the impact of culture on the Therapeutic Alliance and the practice of psychotherapy. We have two questions. I don't know if my of them is in the training of our young.
Dr. Rami, I've lost the sound. Could you try to repeat, please? The only thing I heard was you started off something about training. I'm not sure if you could hear me. I seem to have lost your sound. Could you unmute and ask the question again, please?
Yes, sure. The question was, how would Egypt incorporate a cultural dimension in the training of young psychiatrists in the field of psychotherapy?
Thanks. It's a complicated question because training in every country is determined by the standards that are developed in that country. And in part, they relate both to the system of care as well as the cultural influences that have resulted in that particular system of care. So I think it's difficult coming from one culture, one country, to say how another country should address this. But I think one of the things that used to happen in the US decades ago, it's pretty much disappeared now, is asking trainees to undergo their own personal psychotherapy. This was a sort of reverberation from when Freud originally said that every psychoanalyst should undergo their own psychoanalysis before beginning psychoanalysis. Given time and expense, that's not realistic anymore. So I think a number of programs in different parts of the world have dealt with this by trying to have a group experience for their trainees very early in training, where they would talk about their own experiences of the training, their own feelings about working with certain patients, et cetera. And that this is a less intrusive way of introducing the idea to residents that self-reflection is an important part of the work we do when we try to understand our patient. Another way of addressing this is something that I've personally done for about the last 20 years with our own trainees. And this is in a case conference format. It's not formally considered part of the psychotherapy curriculum, but the topic is the doctor-patient relationship in psychiatric practice. It's a very formal title, but in reality, what it's about is I ask every trainee, and these are first-year trainees, so they're seeing patients on a medical service, on a neurology service. And if they happen to be on psychiatry, they are only seeing people in the emergency department or in the hospital on the psychiatric service. And I asked each resident to present only one time. It's very informal. I don't want them to make any written presentations. I want them to feel as relaxed as they can in presenting to a senior faculty member. And what my instruction is we're only going to talk about a patient who bothered you last week. So this could be someone that you think you care too much about. More commonly, it's about a patient who, for some reason, makes you upset or angry or frustrated. And through talking about the patient with the goal of using our own emotional responses as some data to better understand the patient. So the focus is not on the trainee, it stays on the patient. But by the trainee talking about their emotional responses, we're able to understand what set that off most of the time without getting too personal about the trainee's own background, and use that information to better understand the patient. In this way, residents have an early imprinting experience with using their own emotional responses in a reflective way, which again, in medical training in just about every country, we're pretty much taught not to think about our feelings, that interferes with our judgment somehow. So this gives some early imprinting to the value of self-reflection in understanding the patient. it's indirectly responds to what the psychoanalysts would call countertransference. That is, what emotional responses you're having in response to the patient that may deal with some problems you may have. But we don't talk about personal problems of the trainee at all. We're only focused on what it is in the patient that may have set off that emotional response. I think that's a fairly easy way to introduce thinking about some of these issues.
Thank you very much, Professor Tasman. We have another question for you, sir, regarding cultural adaptation of various psychotherapies to other cultures.
Thank you. Also, a very interesting question. And, during my lecture, I commented on how in the United States, certain people who have very traditional and conservative religious beliefs have difficulty in what we normally consider in the US to be psychotherapy because of this question of, does an individual human have the power to change themselves, or can that only come from God? So figuring out a way to address this is sometimes very important. In the US, this is not confined to any particular religious group. We have just about every world religion somewhere in our country, and patients come to psychotherapy and often have these concerns. So that's one aspect of it. The other aspect depends on the cultural nature of the doctor-patient relationship in that country. Psychiatrists are often and almost always not the first doctor that a patient comes in contact with. In the United States, our evaluation times for general medical problems are very short. And so patients are used to saying, here's what's bothering me. And then the doctor asks many questions about that. So patients are used to being asked by the doctor lots of questions. And then the doctor will think about it and say, here's what I think is wrong, and here's what we should do about it. The nature of psychotherapy, at least the insight-related psychotherapies, are such that we're asking the patient to reflect. So that's another cultural adaptation that's very different in certain countries. Well, in every country, it's different. And you can't prescribe how to address that from one country to another. People working in that country have to find a way of addressing it. So I think the religious aspect of cultural background, or the spiritual belief system of our patients, is an important aspect. The other important aspect is the general cultural relationship between a doctor and a patient, and the context. And that's influenced not only by what we might call the broader culture, but it's also very influenced by the patient's previous experience with either the healthcare or mental health care system, and how other doctors have interacted with them before. So if they've had good experience, they will bring that sort of cultural belief about medicine and psychiatry with them into our office. If they've had bad experiences, they'll bring that with them to us. And it's important that as the physician, as the psychiatrist, that we try to understand all these aspects. And again, I mentioned several times in the lecture, and again, I apologize if the sound was not good and difficult to understand in certain places, but understanding who is the person who has the illness is extremely important. And this is one way of addressing with trainees how to think about the previous experiences with the medical or psychiatric system and any other aspects. It can be an important part, I think, especially early in training, so we get our trainees used to the idea of thinking about these things. In some programs, historically in the US, they didn't address these kinds of issues until formal psychotherapy training got started in the later years of the training program. So in the US, our first year of training is almost all medicine, hospital-based, or psychiatry or emergency services, hospital-based. So there's no specific expectation that psychotherapeutic work is part of the training in that early year. And I think because these kinds of questions historically have been considered only in the context of psychotherapy training, they come in later in the training program when trainees are already imprinted with a different approach. So I think one other aspect about this issue is to start it right at the beginning of the training program. And the idea of implicit bias training, it's not very common in formal postgraduate training these days. It is becoming more common in the US in undergraduate medical education. So in medical school, even if some universities are doing this as well. So I think that would involve a major restructuring of a country's approach. But I think you can do this in your own training program by starting to think about how to integrate this kind of knowledge very early on. So I'll stop there and answer.
Thank you very much. It was very interesting lecture, very interesting very interesting answers to our questions, and we were pleased and honored to have the near future Dr. Tasman.
Thank you. Thanks very much. I see by the clock our time for this is finished, but Dr. Rami, please feel free to communicate with me in the future if I can add any more information about this that might be useful to you. Thanks again. I'm going to sign off now.
Finished, yes.